2022. This is Jens Chapman speaking, and it's such a great pleasure to welcome our colleagues from the University of Maryland today. Drs. David Casper and Dr. Amrit Khalsa will introduce their team shortly, but I was so delighted when I saw that the topic of today's journal club was laminoplasty. This is one of those absolutely almost curative procedures if done right for the right reasons and well. And yet at the same time, when we have our fellows here, so many fellows tell me that they've never done it or that they've rarely done it, or when they tell me how they've done it, it looks kind of very different from what I think it should be looking like. So to explore where we are with laminoplasty and if this is still something, and I misspoke, by the way, I'm so sorry. This is the University of Pennsylvania, not Maryland. I am so sorry. So UPenn, fog of call. I plead innocence. UPenn. So this is a great procedure, and I want to just hear where we are, and all of us are very curious to hear your critical analysis of where we are with laminoplasty. So again, my apologies for misidentifying you, David, and Amrit, please take it from here.
No problem at all. Thanks, Dr. Chapman, and thanks to everyone at the Seattle Science Foundation. We really appreciate the opportunity to kind of go through some journal articles with you today. And I think the real purpose, I changed the title slide to "Where are we today?" with a question mark. And I think a lot of that, as Dr. Chapman reflected on, is, laminoplasty is this kind of black box in terms of the indications for it, maybe the contraindications, and also the technique. So my goals today are have our fellows who have done a fantastic job thus far this year. We have Colin Whitaker, who's going to start with the first article. Just wonderful getting to work with him. He's a great surgeon and also a great clinician as well. And then June Lee, who I can't say enough good things about, is going to be presenting as well. And then my colleague, Dr. Khalsa, he's going to be the other moderator. So again, my goals for today are really to discuss some of the indications and also the contraindications to laminoplasty and where it can fall into practice. And I hope that this can maybe shed some light on some of the more nuanced aspects of the procedure. So with that, Colin, would you mind getting started with the first article?
Sure. All right, good morning, everybody. So my name is Colin Whitaker. I'm one of the spine fellows here at University of Pennsylvania. And as Dr. Chapman alluded to, I am one of those fellows with limited experience in laminoplasty, so good getting some knowledge in this area. Presenting an article comparing the perioperative complications of laminoplasty between OPLL patients and cervical spondylotic myelopathy patients. So this article was published in the Global Spine Journal in 2021 out of Tokyo. It's a retrospective cohort study involving over 22,000 patients. The objectives were to investigate the perioperative complications and also the medical costs of degenerative cervical myelopathy for these patients who underwent laminoplasty, and it utilized a large national inpatient database. So a little bit of background: degenerative cervical myelopathy is due to non-traumatic age-related degeneration with two main diseases in OPLL and spondylosis, both resulting in spinal cord compression with different disease characteristics. Laminoplasty is a posterior based decompression surgery that aims to preserve cervical motion. So as far as the material and methods within this paper, it was informed consent was exempt. The data was extracted from the diagnosis procedure accommodation database, and it utilized ICD-10 codes to identify hospitalized patients with degenerative cervical myelopathy with OPLL or CSM, and also went under laminoplasty. And the patients were divided into two groups, and individual parameters were obtained, such as age, gender, BMI, smoking, all the typical parameters. Also ADL scores, complications, reoperations, and then they were also identified preoperative comorbidities such as diabetes, cardiovascular disease, osteoporosis, and rheumatoid arthritis. And then statistical analysis was performed both before and after propensity scoring, which created a selection bias adjusted cohorts. So in table 1 of the results, we can see the patient characteristics. At baseline, the OPLL group had significantly more patients with diabetes and patients who were smokers, as well as an overall younger patient population compared to the CSM group. The CSM group did have more preoperative comorbidities such as cardiovascular disease, renal failure, and osteoporosis. But you can see here after the propensity scoring matching, there's no significant differences, which made for good comparisons. So table 2 here demonstrates the perioperative systemic complications with the OPLL group having significantly more respiratory issues such as pneumonia and dysphagia, and also indicating that there was more incidence of at least one complication in the OPLL group. In table 3 here, this shows the local complications with the incidence of paralysis and spinal fluid leakage higher in the OPLL group, as well as increased incidence of both wound issues and at least one reoperation within the OPLL group. Table 4 also shows the cost and mortality. Cost was about $2,300 more in the OPLL group compared to the CSM. Mortality and ADLs were not significantly different, but you can see it did approach significance in the CSM group for mortality. Table 5 just shows the overall costs between OPLL and CSM for reoperations. And obviously, we can see here that if you have a complication, it results in higher medical costs, for both groups. So the key points here is that there are more perioperative systemic complications, specifically for pneumonia and dysphagia in the OPLL group, as well as in the local complications was also higher in the OPLL group. Hospitalizations were also higher in the OPLL group. So overall, very good study, very large sample size, 22,000. They were able to directly compare the OPLL and CSM groups, and they did a very good job with propensity scoring matching, creating selection bias adjusted groups. And there were some limitations. It was a database collection. Database was unable to identify some clinically important findings, and as well as the definition of perioperative complications was not optimized. So some standard limitations you would see in a retrospective study of this sample.
So Colin, really nice job. And I think we chose this article because the vast majority of the historical literature on laminoplasty was for the treatment of OPLL. And then I think we saw a little bit of a transition based on the concept that OPLL may progress with preserved motion. So it kind of went in the opposite direction and predominantly using it for spondylotic myelopathy. But I think the pendulum's kind of going back in the other way, and it's really becoming a procedure that with certain preoperative counseling can certainly be used in the setting of OPLL. Dr. Chapman, I may propose this question to you in relation to your clinical practice. You know, if you see a patient that's on the younger side, you know, maybe mid-50s, has significant OPLL in the subaxial cervical spine, you know, what kind of aspects are you looking at, whether you're going to decide to fuse that patient or potentially do a laminoplasty surgery?
So well said, Dr. Casper. Indeed, this is a procedure that was born out of OPLL treatment concerns. And de facto, it seems that the inflammatory nature of this disease process seems to progress with continued motion along the tension and flexion sides of the vertebral body. So the OALL and OPLL will actually progress. It may be clinically relevant, it may not be clinically relevant, but I basically nowadays think that OPLL should be treated with a fusion to arrest the inflammatory disease process. So the very procedure that we started doing this for, we don't use it for anymore. Instead, in select patients, it's CSM. So my practice has changed totally over time. And I don't know how it is with you, but I think that a posterior decompression infusion is actually, as sad as it is, because we have to usually do multi-level fusions, it's actually a very definitive procedure. Thank you for asking.
Yeah, no, I certainly echo those sentiments, and that's exactly hitting the nail on the head. I think the trouble comes in when you have a patient, that's, the mid 50s going on 35, and they're an avid golfer, or they're a swimmer, or they're a cyclist, or, they have these underlying issues and kind of social factors that play into the decision making. So I think it often revolves around a conversation as to what the next 10 to 15 to 20 years of their life looks like and what their ultimate goals post-operatively are. Maybe Dr. Kalso, just in the interest of time, would you mind commenting potentially on your practice, and is there a role for laminoplasty in OPLL? And then we'll transition to Dr. Lee's article.
Yeah, thanks, Dave. I tend to agree with Dr. Chapman overall, that I think really robust OPLL. In an otherwise good fusion candidate, probably safer to lean in that direction. But I think that the flip side of the counter argument, maybe we know we see increased rates of OPLL in our diabetic population. You maybe get a poorly controlled diabetic with progressive myelopathy with concurrent OPLL, and they just have a lot of risk factors setting themselves up for pseudoarthrosis. So I will sometimes still do a laminoplasty, for the opposite reasons, not our younger quote unquote healthy patient, but the flip side of our concerning patient that might not be an ideal fusion candidate. I have quote unquote gotten away with and had good success with laminoplasty kind of in that scenario as well. And again, this is kind of that gray area. This is why talking about laminoplasty is so great, because there's still everyone's kind of got their own opinion, and they're all valid.
Agreed. Yeah. Thanks very much. June, would you mind getting going with the next article, please?
Sure. Yeah. So my name is June Lee. Welcome to Seattle Science Foundation. Can you guys hear me okay?
Yes.
Okay, great. So I'll be presenting an article called Kinematics After Cervical Laminoplasty, Risk Factors for Cervical Kyphotic Deformity After Laminoplasty. So this is a study done out of South Korea by a group with Dr. Kim. The background, so why are we studying this? Post-surgical kyphosis after cervical laminoplasty is a known adverse effect, and the risk factors / predictors for the post-surgical kyphosis have not been sufficiently validated thus far. So the purpose of the article is to assess the risk factors for post-surgical kyphosis following laminoplasty. This is a retrospective study. Patient sample, they looked at 53 patients with CSM or OPLL who underwent laminoplasty between May 2011 and October 2018. And they did at least 3 levels of laminoplasty. The technique they used were both the open door or the French door laminoplasty. And they excluded fractures, infections, tumors, combination with fusion, and combination with anterior approaches, previous surgeries, and those patients who are lost to follow-up. So they collected imaging data from both the neutral and flexion extension radiographs at baseline and at 2 years follow-up. The range of motion from neutral to complete flexion and from neutral to complete extension were also measured. So this is just a diagram of the different angles that they measured. Alpha here is the C2 to 7 lordosis. Beta is 2 to 7 range of motion. Letter A is the flexion capacities from neutral to flexion, and then letter B is neutral to extension. So the other measurement they made was C2 to 7 SVA, as displayed here, and this T1 slope. So what did they find? Smaller pre-op extension capacity led to a greater loss of lordosis, as one could imagine. A larger T1 slope that also led to a greater loss of lordosis as well. C2 to 7 lordosis increased with increasing baseline T1 slope, which makes sense. Larger pre-op C2 to 7 lordosis led to more post-op range of motion decrease. And neither the degree of lordosis nor the range of motion reduction demonstrated clear correlation with clinical outcomes at 2 years after surgery. So here you can see table 4 just displays the linear regression analysis of the relationship between the pre-op cervical alignment and post-op decrease in cervical lordosis. So the C2 to 7 angle, you can see here that the T1 slope was, so a greater T1 slope led to a greater decrease in cervical lordosis. However, a greater C2 to 7 extension capacity led to a smaller actually decrease in cervical lordosis. So it's in the opposite direction. This also reached statistical significance as well. In table 5, you have the linear regression analysis of the relationship between the pre-op cervical alignment and the post-op decrease in range of motion. Here you can see that really just the C2 to 7 flexion capacity reached significant statistical significance in the multivariate analysis. Here's table 6 showing the linear regression analysis of the relationship between pre-op cervical alignment and post-op increased SVA. And you can see none of these variables that they measured reach any significance statistically. So in conclusion, post-operative kyphotic changes in cervical spine following laminoplasty were related to pre-op radiographic parameters. The greater the pre-op extension capacity, it led to a lower loss of lordosis. And the greater the T1 slope, the greater the loss of lordosis as well.
Thanks, Yoon. Very nice job. And I think we picked this article because it highlights, some parameters that might be worthwhile looking at preoperatively. And Yoon, do you gather from this that the T1 slope, now obviously the greater the T1 slope, we're talking about a little bit more of a shear force through that area. Does that make sense to you in terms of the T1 slope being increased and causing issue in relation to alignment postoperatively?
Yeah, definitely. If you think about it, a T1 slope, if it's parallel to the ground, then that would be a 0. And if it's 90 degrees perpendicular to the ground, that would be 90 degrees. So the more forward tilting you were pre-operatively, the more of a stress, a torque will be acted on the head, right? So, so with the surgery of, detaching the posterior muscles, I think in my mind, it makes sense. Just, theoretically, there's fewer forces holding the head back, right?
No, I think it's very important, and I think it's leading people to potentially get more standing X-rays from a scoliosis perspective in relation to the sagittal alignment in relation to laminoplasty surgery. I think what is also important when we talk about range of motion post-operatively is a lot of the initial studies that were done had patients in a hard cervical collar for 2 weeks. And so I think from that perspective, I think we've made some advancements in that. And so what I'd like to do, and I know we have Dr. Chapman on, and I'd like to pick his brain when it comes to this as well, is oftentimes when we think of preoperative alignment, patients that are lordotic, we say, okay, thumbs up for laminoplasty, but then we start thinking neutral, maybe a little bit of kyphosis, we start scratching our heads more. So Dr. Chapman, would you mind commenting first on, your kind of alignment parameters preoperatively, and then potentially your postoperative protocols, whether it be a hard cervical collar, soft collar as needed, or no bracing whatsoever?
So thank you for the question. And Dr. Lee, I second Dr. Kasper's comment. Great article, great insights and discussion. And the T1 slope angle, I really have to credit our ISSG colleague, Dr. Ames from UCSF, for having kind of opened our eyes for this. So the alignment issue relative to significant clinical cervical stenosis is really overlooked because many patients acquire a kyphosis as an escape posture. So they basically bend forwards, whether it's their neck or their low back, to give themselves those 1 to 3 millimeters of extra canal space by unbuckling the ligamentum flavum, just a little bit more breathing room. So I find this always fascinating how you can actually get some improvement in alignment just by giving the cord this extra space. In terms of alignment parameters, for me, the key thing is that highly functional people without connective tissue diseases can actually really resume a very literally unrestricted lifestyle. And clearly patients with significant extremes of compensatory mobility, for instance, a very significant thoracic kyphosis who hyperlordose their neck, are probably not good candidates. Dr. Lee, I'd turn the question back to you. Do you think that that's a fair assessment as a conclusion of the study from Korea? So a hyperlordotic neck due to a thoracic malposition is not a good candidate? Did I understand that right?
Yeah, so in the article itself, they did say that that was one of their limitations. Most of their patients only underwent a lateral C-spine X-ray, and they did not look at global alignment, which I think is very important as well. Yeah.
For me, the other big thing that this article did not address that goes into alignment but beyond is translational instability. So if people have sagittal or monosegmental or multisegmental instability, such as due to a inflammatory arthropathy, for instance, I would find that to be a contraindication. So in terms of outcomes, maintaining mobility and having a relatively physiologic neck is very important. In terms of the decision-making of when is there a kyphosis that would be a contraindication, and I think everybody's books, I have changed towards accepting patients who can achieve a good lordosis with active extension, but I will consider a laminoplasty in patients who have a straight neck, assuming again that this escape posture where patients flex their neck forward to give themselves more room is a factor. So those are my thoughts. I don't know whether they contribute anything or answer your question, Dr. Kasper.
Absolutely, very much so. And I echo those sentiments. And I think that we're starting to maybe understand a little bit better the importance of global sagittal alignment in relation to the overall success of laminoplasty surgery and some of those compensatory mechanisms. So I think that's important. Dr. Kalsa, in terms of your postoperative protocol, making sure that these patients hopefully regain as much of their mobility as possible, what types of protocols do you have in place?
Yeah, thanks, Dave. So, I'll basically offer a patient a soft collar. So I don't hard collar any of my laminoplasties. And I pretty much just try to get them up and moving, as soon as possible. I'll give them some weight bearing restrictions for usually about 2 to 4 weeks after surgery, but I like to get them moving early and often. And I find that, that early mobility can kind of help with down the line as far as their postoperative neck pain. So I am really a proponent of, this is a motion preserving procedure. I know that the counter argument is, yeah, we need that trough side or whatever technique you're using to kind of heal in per se. But I tend to be pretty aggressive with my postoperative mobilization. And thankfully, thus far, have not had any major concerns.
Agreed. Thank you. Yeah, my protocol is similar in that I offer them soft collar. At 2 weeks, I see them back. As long as their incision looks good, I'm getting them enrolled in physical therapy. And I have a great physical therapist who really works with them in relation to chin tuck exercises and maintaining a vertical gaze and almost vertical gaze. And I think that really helps them to get back so that by 6 weeks, I think oftentimes these patients are doing quite well and able to return to a lot of activities that they otherwise would want to. Shun, thanks very much. I think this article kind of highlights that we need to dive deeper into global sagittal alignment in relation to laminoplasty, because I think we're still scratching our heads a little bit in relation to what patients are able to maintain range of motion, but at the same time may end up with some of that kyphotic deformity postoperatively. Colin, are you okay to get the ball rolling with our third article?
right, so our third article is evaluating the relationship between the C2 semispinalis preservation and C2 spinous process morphology during laminoplasty that involves C3. So this was an article that was published in Global Spine Journal 2021. It was out of Korea, and it was a retrospective study, involved 95 patients. So the objective of the study, due to anatomical variations in the insertion of semispinalis at C2, preservation was not always possible in all of these cases. So they did a three-dimensional CT was used to evaluate the relationship between the incidence of semispinalis injury and the C2 interspinous angle. So a little background: laminoplasty complications may arise due to the extensive muscle dissection and injury to semispinalis. And we know that the semispinalis plays a key role in the dynamic stability of the cervical spine. So preservation is difficult when we're performing C3 laminoplasty or laminectomy when it's involved. The article went into why laminoplasty, including C3, is difficult in preserving semispinalis, such as the course of C2 semispinalis originating from the T1 transverse processes, the tensile forces that are acted upon the semispinalis when we position the patient in the kyphotic deformity during surgery, and then the inherent vulnerability of the muscle fibers. So like I said, this was a retrospective study, 95 patients who underwent a cervical laminoplasty as well as a C3 laminectomy. There were several exclusions, such as previous surgery involving C3, whether that was a laminectomy or a laminoplasty, also anterior surgery, preoperative range of motion less than 5 degrees due to OPLL or DISH, preoperative neck pain greater than 3, and a canine negative patients were all excluded. All these patients had 3D CT angios preoperatively, and they were used to evaluate the C2 spinous process morphology. They were divided all into two groups, whether their interspinous angle is greater than 60, which was considered wide, or less than 60 degrees, which was considered narrow. They went into their operative technique. This was all done via single surgeon, so the good consistency with the operative technique. Semispinalis preservation was attempted in all cases, but detachment was performed if visualization was required. They performed a unilateral open door laminoplasty and a C3 laminectomy, and they utilized 2 screws and a plate. If the semispinalis was detached, it was reapproximated, and the was used using sutures depending on the extent of the detachment. So this figure 1-2 here just illustrates the different morphologies with the wide angle on the right of your screen and the narrow angle on the left of your screen. As far as the materials and methods moving forward, the radiographic analysis, the C2 spinous process, T1 transverse morphology, as well as the distance between the C2 spinous processes and the T1 transverse process, C2 interspinous angle, and the semispinalis cervicis muscle angle was also recorded. Postoperatively and preoperatively, the neck pain disability scores were evaluated. And here's a good illustration of the different types of measurements that they took. Over on the left is the C2 interspinous angle. In the middle here, figure B, is the C2 interspinous distance that was measured. And on the right of your screen in figure C is the semispinalis muscle angle, which was recorded. As far as the results, here's table 1 demonstrating the patient demographics, which were evenly distributed throughout the two groups, such as age, sex, and the type of disease, whether that was OPLL or spondylosis. Overall, C2 semispinalis was preserved in 64% of all patients. But if you move to the right of your screen, you can see that in 97% in the wide angle was preserved, whereas only approximately 30% was preserved in the narrow angle group, which was statistically significant. In the comparison of radiologic factors between the two groups, we do see significant differences in the C2 interspinous diameter and the semispinalis muscle angle between the narrow group and the wide group as well. There was no significant differences in the pre-op or post-op alignment besides the extension lordosis in the narrow group. They did note that there was a non-significant difference in the post-operative range of motion. Figure 4 here is just showing us an example of the normal angle patient at the top and the wide angle patient at the bottom, demonstrating the difference in extension lordosis between the two groups. As far as clinical factors that were evaluated, there was a significant difference in the VAS pain scales, with the narrow group having significantly greater pain scores post-operatively. So the key points in this article, C2 semispinalis was preserved in 30% of the narrow angle group and almost 98% of the wide angle group. And the post-operative C2 to 7 lordosis extension and range of motion were significantly greater in the wide angle group. Post-operative neck pain was significantly greater in the narrow angle group. Was some limitations in the study. All the procedures were not performed at the same level, whether that involved C4, C5, 6, or 7. It was a retrospective analysis, and different techniques are used to preserve and reapproximate the semispinalis. So it depends on surgical skill level as well.
Really nice job, Colin. And I think this is a really interesting idea that highlights something novel that we might not always think about as far as the the morphology of the C2 spinous process and the attachment of the semispinalis muscle. I think, I don't know if we're all going to proceed with moving towards getting preoperative CAT scans to necessarily, firm up this morphology, and whether or not that's going to dictate the candidacy for our patients, whether or not we're going to choose laminoplasty maybe over other options based on this. But there's clearly some value here as far as maybe being able to identify some of these factors preoperatively and better counsel our patients as far as this perceived risk of postoperative pain in this narrow-angled population. So I think it's really, really interesting what they've done here. I think naturally this does bring up some discussion regarding the benefits and necessity of C3 laminectomy for a laminoplasty that's involving the C3 level versus simply just including it in your lift with the rest of your plasty. I'd love to hear some of the thoughts. Maybe Dr. Chapman, would you mind expanding on, in your practice, have you transitioned to the C3 Lami, or do you stick with the tried and true full plasty here?
So first of all, thank you, Colin. Thank you, Dr. Whitaker, for teaching me. I mean, this is why I love these sessions, and I love Journal Club and having bright young minds open our eyes for new things. So I had never heard of or contemplated the angle, and Dr. Hart is behind me here, contemplated the angle of insertion of the semispinalis to be relevant, and clearly being far more cognizant and intelligent about what muscle structures and tendon attachments specifically matter and how to preserve them or repair them properly is a big deal. So I appreciate the learning opportunity. In practical reality, first of all, when we do laminoplasty, we should do it safely. And I frequently struggle with the thought of preserving tendon attachment C2 in a more difficult anatomy when that compromises my see-through laminoplasty. I always think we should do what we need to do to have a safe execution of a quality release or decompression of C3. The C3 laminectomy part, I'll come frank out. I've heard this in meetings now for many times by many great colleagues who I highly respect, and I've just never seen this to be a actual meaningful addition. I think it's one of those examples of this another variation of this over varied procedure. I think the flaw of laminoplasty is that there's so many different variants that have names attached to them. I've just never seen a clinical reality. And again, I just simply do everything as one ligamentous block and leave that nicely intact and elevate everything. I will probably release the ligamentum flavum between C2-3 or undercut C2 to get that nice elevation up. But actually taking the whole lamina out, I've just never understood the concept of it. But yes, you can get away with it. So no benefit, but another variant. May I ask my partner, Dr. Hart, do you mind taking your microphone there, Bob? C3 laminectomy, yes, no?
No, I've never done it that way. I always laminoplasty all the levels that I'm operating on. Yeah, the only variant I have is that I don't put a graft at all 3 levels. I do a unilateral hinge and I graft. If I usually do 3 through 7, and I graft 3, 5, and 7, and leave 4 and 6 open, which I just find technically easier, and I think may allow greater mobility to the patient.
No, I think. Go ahead, Dave.
Dr. Hart, when you say graft 3, 5, and 7, when you're doing the procedure, are you using a plate and also an allograft bone block, or do you mean you're placing plates on 3 through 7 and then skipping the allograft bone block? What's your technique from that aspect?
I do use the allograft since that's been available, but I'm old enough that that device didn't exist when I started, and I was using just a suture anchor and a piece of graft that I'd cut for myself. But since that became available, I've availed myself of it. I think it's a convenient way of doing it. So plate with a little structural allograft at 3, 5, and 7, and I leave 6 and 4 open.
Thank you.
Dr. Hart, your suture technique probably worked fine though, right? I mean, as you said, it was probably more of convenience. Is that kind of how you describe it?
Yeah, I'd say that's why it worked.
Yeah,
it seemed to work. It was floppy, yeah. And it was, but it retained mobility well, I guess.
Hey, I want to say something. So I've been to Japan. I admire the absolutely beautiful technique of so many of the colleagues there. But this is one of the big differences in the Japanese literature. I think roughly 30% of patients have ongoing neck pain, and most of these patients are very stoic individuals that I've seen. And by the way, just as the first article identified, have a BMI of 24. Who has an average BMI of 24 in North America? Anybody? No takers? Okay. But the point is the following. Having a rigid posterior segment fixation, I think, decreases neck pain, and having these suture anchors that can break despite best efforts, I think adds to non-unions, adds to secondary closure, which is unheard of if you restore the posterior arch in a semi-rigid fashion with a plate. So I think that this is one of those things where, again, improvisation has been interesting and low-tech approaches have been very compelling. But I think that the most predictable result is to restore the posterior arch in a semi-rigid fashion with a little plate and screw fixation. That's just my thought. And this is what I asked the young generation who is interested in laminoplasty to study comparatively. I personally hypothesize that a posterior rigid fixation, a semi-rigid fixation of the arches reduces neck pain postoperatively. My thoughts, and makes secondary closure a forgotten thing.
Do you use an bone block as well, Dr. Chapman, in addition to the plates?
Yes. I'm conflicted. I designed one of the earliest sets for one of the larger manufacturers, but I use an allograft and I use plates. I'm old enough, I cut my own allografts from rib allografts that I harvested, and I took craniofacial plates and put them into the back of the arches. And so having pre-manufactured allografts with little notches is an amazing thing, and having pre-contoured small plates is just a very aesthetically pleasing procedure.
Yeah, I tend to agree with you. I'll take the devil's advocate approach, though. I actually have started doing a C3 laminectomy, and I do use plates in a open door technique, but I have used the C3 laminectomy technique probably over the last 2 years. And, I find no difference in my outcomes. I think patients still do generally well with this procedure when appropriately indicated. And I do find that there is an ease, and maybe it's just my fumbly hands here, but there is an ease to doing the C3 laminectomy, both from working under the semispinalis muscle. I do find I actually use a ultrasonic bone scalpel to perform my bicortical cuts. And so I'll do it obviously bilaterally at C3. And I do find that allows me to kind of sneak under the muscle and take down a little bit less of it. And that's just me, in my practice. I clearly don't have the nuance of these authors of this paper to notice this differential morphology. You're doing your laminoplasty and, there's the muscle belly. Let's try to preserve as much as we can of it. And that's kind of my thoughts. But I also find for the patients that need the C2 dome laminectomy as well, it's a little bit more facile having a wide open 3 rather than a hinge 3 lamina to be able to really get under there to avoid further disruption at the C2 level. So it is one of those things that I do think that there is, it's just a little bit more facile in my hands, and if there's no ultimate difference, from patient outcome standpoint, I do like doing it. But I think, like we're all noticing, there's just so many different techniques here, and overall, just a great procedure. But I think to Dr. Chapman's point, parsing out, having a lot of experience with this procedure and understanding, who's having the neck pain down the line, because we all have those patients, and trying to do our due diligence for minimizing that in our own population is important. So I think with that, we'll pass back to Dr. Lee for our final article of the morning.
Thank you. So the next article that I'll be presenting is titled Multilevel Posterior Foraminotomy with Laminoplasty versus Laminoplasty alone for cervical spondylotic myelopathy with radiculopathy, a comparative study. So this again is done by a group in Korea as well, headed by Dr. Lee and Dr. Ha. So some background: conventional laminoplasty is useful for expanding a stenotic spinal canal, but the limited use for decompression, it has a limited use for decompression of neuroforaminostenosis. So a concurrent foraminotomy can be performed, but carries the risk of segmental kyphosis and instability. That's a risk. So the purpose of the article is to elucidate the surgical outcomes of concurrent foraminotomy with laminoplasty for CSM with radiculopathy. So this is a retrospective comparative review. Patient sample, they looked at 98 consecutive patients that were screened for the study between 2006 and 2021 or 2012. 66 of them met inclusion criteria. So the inclusion criteria include laminoplasty at 2 or more levels and follow-up of more than 2 years out post-operatively. Again, here's the inclusion and exclusion criteria. Unlike the first article that I presented, they excluded actually those with OPLL, and the other exclusion criteria were pretty similar. So in terms of outcome measures, they looked at both clinical and radiographic. Clinically, they looked at the Neck Disability Index, the Japanese Orthopedic Association scores, the JOA recovery rates, and the visual analog scale. Radiographically, they looked at the C2 to 7 sagittal vertical axis distance, the SVA, the cervical lordosis, range of motion, and angulation and listhesis at the foraminotomy level. So they used just the open door laminoplasty technique with a laminar cut on the side with the more symptoms. So if the patient had more symptoms on the left side, then they opened it on the left side, and vice versa. they resected less than 50% of the medial edges of the facets. They did use a microscope in all their cases. And at the end of the case, they reattached the deep extensor muscles to the insertion sites and braced the patients for 4 weeks. So here's a 3D CT of their results. So the one on the left is with a foraminotomy. The one on the right is without. So they had 66 patients with cervical spondylotic myelopathy and radiculopathy involving 2 or more levels followed for at least 2 years. The first 26 patients were treated with laminoplasty alone, and the subsequent 40 patients were treated with laminoplasty and foraminotomy. This resulted in 78 cervical segments and 99 neural foraminae, with 21 of them being bilateral foraminotomies. So the results: NDI, JOA scores, JOA recovery rates, and VAS for neck and arm pain were significantly improved in both groups, so both with and without foraminotomy after surgery. The improvement in the VAS score was significantly greater in the laminoplasty with foraminotomy group than in the laminoplasty alone group. And for cervical lordosis and range of motion, they were decreased postoperatively in both groups equally, which is about 70 to 75%. Postoperative focal angulation and listhesis were slightly increased in the laminoplasty with foraminotomy group compared to those without the foraminotomy, but this did not reach statistical significance. The segmental kyphosis and instability were not observed in the laminoplasty with foraminotomy, whether the patient underwent a unilateral or bilateral foraminotomy. So table 3 just illustrates the clinical outcomes of the additional posterior foraminotomy with laminoplasty and foraminotomy alone, or laminoplasty alone group. You can see here the NDI in the group that they did perform the foraminotomy, the NDI JOA score and the VAS for arm pain were all reach statistical significance, whereas in the ones without the foraminotomy, only the VAS for arm pain shows significance. Figure 4 here just illustrates the different measurements that they made. Table 4 here illustrates the radiographic changes in the additional foraminotomy with laminoplasty and laminoplasty alone group. So you can here see that there is a decrease from 40 degrees to about 30 degrees in range of motion in those who underwent the additional foraminotomy, whereas all the other parameters did not reach significance in either group. Table 5 here shows whether any segmental kyphosis and instability occurred or not in those with foraminotomy, either unilaterally or bilaterally, and it did not, as you can see here. So conclusions: laminoplasty with foraminotomy improved arm pain better than laminoplasty alone, although laminoplasty alone, as you recall, did help as well. Multi-level foraminotomy or bilateral foraminotomy did not affect segmental malalignment or instability.
Really nice job, Jun. I think that this paper is very valuable to show us that in this population, you can quote unquote get away with doing a multi-level posterior foraminotomy and not have the patient absolutely collapse into devastating kyphosis. I do think about this paper kind of brings it up. Clearly, I think a lot of us, as far as our indications go for laminoplasty, a hard and fast one is, or at least a contraindication is significant axial neck pain. In my own practice, I'm just, debating, how do you really differentiate axial neck pain sometimes from some of the referred pain from radiculopathy? And I just wonder, in the US, how many of these patients are just kind of reflexively getting fusions And how do you really tease out some of that axial neck pain versus, let's say, a more cephalad cervical radiculopathy or just muscle spasm from that, versus, the real clean indication is no axial neck pain, pure myelopathy. That's a home run for a laminoplasty, obviously. So, before I open up to the panelists, June, what was your experience kind of in your training as far as managing patients with laminoplasty? And would any of your faculty members back at Brown do a multi-level foraminotomy, or would they consider hybrid constructs, or just too much radiculopathy, contraindication to laminoplasty?
Yeah. Again, it's a mixed bag, because even within the group, there's no consensus. Everybody does it a little bit differently. Some of them, if there is clear like a segmental radiculopathy, though, one of the attendings would go and do the or do the foraminotomy. But some people, I don't think anybody did bilateral foraminotomy. It's just regularly on all the levels. I think that struck me as a little bit different when reading this article.
Yeah, absolutely. Dr. Casper, I'm gonna kick it over to you. Through your experience in practice and back through training as well, would you guys start to dabble in some of these hybrid constructs, or clearly, this paper is presenting a population where laminoplasty is really getting utilized. These guys are just masters of this procedure, and subsequently they're kind of adding on additional nuances to make it successful in their hands. I just wonder, have you seen that translate in your own practice with these kind of constructs? Where do things stand with you?
Yeah, absolutely. And we had a thoughtful question in the chat box. It's interesting when you start thinking about bilateral radiculopathy at the same level, and you're doing foraminotomies at the same level. Does that weaken the hinge side? And I think it does. And so in my hands, who's the patient that's getting a laminoplasty and foraminotomy? Well, it's the patient with myeloradiculopathy that has unilateral, isolated to one level radiculopathy. And in that patient, I think a laminoplasty is reasonable. And again, I would elevate, C3 to 7 or whatever it may be, and do the isolated unilateral foraminotomy at that level. When we start talking about bilateral radiculopathy that is debilitating in nature, oftentimes that lends itself in my hands more to an anterior approach. And I think that's where we start talking about the hybrid constructs, and potentially, if they have myelopathy that's stemming from compression of their entire subaxial cervical spine, then it would lead me to probably do an isolated one-level ACDF at the complaints of their bilateral radiculopathy, and then do a multi-level laminoplasty to open up the remainder of their cervical spine. So that's kind of in my practice. A foraminotomy is usually reserved for unilateral one-level radiculopathy.
Yeah, and that makes a lot of sense. I think, interesting enough, in this paper, and obviously the N is fairly low, but they were able to show no C5 palsies, and I know that's a little bit of a different beast here, postoperatively in their foraminotomy group, and they had 2 in their non-foraminotomy cohort. So that gets into the whole debate as far as, is there truly a protective effect with severe underlying foraminal stenosis at 4-5 to just doing a bilateral foraminotomy? I'll tell you, I personally kind of go back and forth. I do a laminoplasty and I get a C5 palsy. I'm doing bilateral foraminotomies probably for the next couple months, just because it's so devastating for our patients oftentimes. So I'd love to hear the thoughts of Dr. Chapman and Dr. Hart, maybe as far as what their thoughts are as far as the potential for destabilization with aggressive foraminotomies in the setting of a laminoplasty, and then okay or not okay with the addition of some anterior work to supplement maybe bilateral foraminal stenosis.
Amrit, you put a big smile on my face by talking about C5 palsies, because I have exactly followed that pattern of doing more aggressive C5, so C4-5 decompressions preemptively. And whenever I have a palsies, and I realized I've not done them as aggressively as I used to. So fault myself. Let me expand for a second. I think that as we plan laminoplasties, I think it helps us to be more thoughtful as to the laterality, meaning which side we hinge them open, assuming we do an open door laminoplasty. And frequently patients have an asymmetric cord compression from oncovertebral disease. So the answer is I really advocate for doing a laminoplasty in the opening side on the side of more cord compression. I think that's a significant kind of individualization that has been overlooked. And again, fellows always ask me, do you do right or left side? And I go like, it depends. It depends upon where there's more cord compression. In terms of number of foraminotomies on hinge side or not, again, I just outed myself. I do perform, as I do the initial trough cuts, a preemptive C4-5 foraminotomy and use 1 and 2 millimeter keratins and very small curettes to get a clear passage of the C5 root established. And I do that before I hinge everything open. And it makes me feel better. Honestly, I can't give you any de facto data. Now, in terms of how many foraminotomies to do, again, I admire the beautiful technique and the really nice images of our colleagues from Korea. I side with the great Howard on a pragmatic basis. Once you have to do more than 2 levels of foraminotomies max on one side, you probably should reconsider your surgical approach. It just starts becoming a losing proposition, and the gains of a decompression get lost in the shuffle of an advanced spondylosis. So I think that I just quote Howard on 1 or 2 levels, one side, perfectly fine. More, reconsider. Bob, any thoughts from your end?
Yeah, I don't know that I have a lot more to add to that. I certainly consider a C5 foraminotomy essential, or C5-6, or really about the middle 3 levels. I think it's an essential part of the procedure. If you do very many of these, you definitely see C5 palsies. It's one of the very few complications I've seen in this procedure. So I'm a fan of laminoplasty. I think a lot of us have moved maybe more towards fusion, and that's true of me too. I probably do more fusions now for patients that I might have done a laminoplasty a few years ago, but I definitely think there's still a role in it for it. It is motion preserving. My results have seemed to show a good mobility post-op in almost all the patients that I can recall. I know a lot of surgeons also talk about post-operative neck pain. I'm sure that there obviously is going to be some pain for patients if they retain mobility, but I haven't found that to be an overwhelming difficulty. But C5 palsies are definitely real. Some of them are definitely permanent and impairing. And so anything we can to avoid that, I think, is critical.
Yeah, those are both very valuable insights. We really appreciate that. So I think we're reaching the end here. I'll kick it back to Dr. Kasper just to close it up.
Thanks, Amrit, and thanks everyone for the thoughtful discussion. I think, obviously this is a procedure that needs more investigation. Population's heterogeneous, the procedures themselves are heterogeneous. So I think obviously, hopefully more to come. As always, thank you to the Seattle Science Foundation for letting us host. We really enjoy these opportunities and really appreciate the strong work by our fellows to present the articles. So thanks everyone, and thanks for your participation in the conversation.
So from Seattle, Drs. Kasper and Kalsa, thank you, and your 2 fellows, Drs. Lee and Whitaker. Great topics. So happy to see that reflected. Critical, good new articles with interesting thoughts on variations and nuances that were coming up. UPenn, you did a great job, and we really appreciate, and I appreciate the education I got today. So thank you very much. Stay safe, heads up, and see the good in life and do good. Take care. Bye-bye.
Thanks, everyone.
Thanks, everyone.